Dear Professor, dear colleagues, thank you, Dr. Asila, for introduction. Yes, this is a debatable question and debatable issue in the venous practice. How we deal with such type of patient with post-phlebitic venous leg ulcer. Today we will go for the outcomes of thermal ablation for this patient with superficial venous reflux in the presence of DVT with recanalized DVT. So our study aim of work was assess the healing time and procedure-related complication and recurrence rate in patient having post-phlebitic venous ulcer after being treated with EVLA associated with ultrasound-guided sclerotherapy to incompetent perforators and compression therapy. So it was a prospective observational study in Ain Shams University Hospital and Nasser Institute Hospital in Cairo, over 30 patients who have had post-phlebitic venous leg ulcer. Our inclusion criteria is non-healing venous ulcer of more than 2 months and one attack of ipsilateral lower limb DVT not more than 6 months, with radiological evidence of complete recanalization with concomitant deep and superficial venous reflux, and the patient who had an iliofemoral DVT and were treated with iliac stenting and patent. Our exclusion criteria was the patients with untreated osteomyelitis, infection, deformity, and known to have diabetes mellitus, and with patients who have ankle brachial index less than 0.9 to exclude unfeasibility of compression therapy, and any patient with partial recanalization or no recanalization of the system. Pre-intervention, all patients were subjected to careful history taking and assessed according to venous clinical severity score. Venous duplex examination was done twice to determine the state of recanalization of deep system, and CT venography to ensure the patency of iliac veins and previously applied stents for previously treated iliofemoral DVT. In the follow-up of in such a study, all patients were examined for signs of DVT and other complications related to procedure like thrombophlebitis, cellulitis, skin gangrene, lower limb edema, neuropathy, and postoperative pain. Prophylactic anticoagulation was used for 1 month postoperative. All patients were followed up in 1, 3, 6, and 12 months. Patients were examined and venous clinical score was recorded as well for follow-up. After 1 year, 90% of cases has totally healed ulcer, 10% of ulcer decrease in size more than 50%, and recurrence rate was 6.7%, and the adverse effect was between hematoma, ecchymosis, thrombophlebitis, pain. There was a significant improvement in venous clinical severity score regarding the pain and edema and the inflammation and ulcer size. This is some of our demographic data for our study and comorbidities, also for follow-up pre and after 6 months, and pre-operative and after 6 months for pigmentation, inflammation, induration, ulcer number, ulcer size, and compression. Also for improvement, for ulcer improvement more than 50%, less than 50%, and ulcer improvement totally healed, like we see in the graphs. This is some of our cases in the study. Complication, like I said, between DVT, infection, hematoma, ecchymosis, thrombophlebitis, and pain like paresthesia. This is some of literature and some of studies. There is a scarce studies about this debatable issue. This is one of the studies, venous reflux in the patient with previously deep venous thrombosis correlation with ulceration and other symptoms. Its conclusion, the data suggests that as far as skin change and ulceration are concerned, distal reflux and reflux in superficial vein are more harmful than reflux confined to deep system, even when such reflux extends throughout the deep venous system. Minimally invasive interventions such as venous stenting and superficial venous reflux are relatively simple with good efficacy and low risk when obstruction is associated with reflux. Concomitant superficial reflux may be treated in the same setting, but any associated deep reflux is ignored pending clinical response to this intervention. Peter Neglin says the prevailing view that intervention can only be performed after failure of conservative treatment may deprive patient of early substantial symptom relief. Invasive and conservative treatment should be used simultaneously as appropriate and don't conflict with them. The decision to intervene based upon the clinical status of the patient and the type of intervention directed as a result of adequate investigation. When obstruction is shown with reflux, obstruction should be treated first. When concomitant superficial reflux, usually great saphenous reflux, is present, we are now increasingly combining stenting with percutaneous catheter obliteration with or without many phlebectomies in the same setting, treating varicose veins in patients with DVT. In this paper, vein closure in patients with a history of deep venous thrombosis is achievable and may lead to beneficial result, but further research is needed. There has been one study demonstrating that surgical stripping of saphenous vein is possibly beneficial with patients with chronic DVT. Due to scarcity of literature addressing this patient population, we need more and more studies. Treating varicose veins in previously DVT present a big challenge for clinicians, and these patients are usually quite symptomatic due to advanced venous insufficiency, resulting in the poor quality of life. This was also one of the studies, Guini et al., compared 29 patients with previously DVT with 264 patients without previous DVT. Their superficial reflux was treated with radiofrequency ablation with variety of other procedures like phlebectomy or perforator treatment. The incidence of recurrent DVT was 7% and 14%. By analysis, large proximal grade saphenous vein and previous DVT were significant risk of recurrent DVT post-procedure. Raju et al. Also studied patients with chronic venous obstruction due to previous DVT. Surgical removal of saphenous vein didn't lead to worsening of the venous obstruction, but provided significant clinical relief. Our conclusion, patients with totally recanalized DVT presenting with non-healing ulcer may benefit from thermal ablation of superficial vein with combined ultrasound-guided and compression is safe, effective, and feasible procedure. Thank you.